I'd like to next introduce to you Dr. Carol Koski. She is the medical director and a member of the Medical Advisory Board for GBS and CIDP Foundation International. She retired from the University School of Medicine in Baltimore in April of 2006, where she served as a professor of neurology and director of the Neuromuscular Division and Physicians Infusion Clinic in the Department of Neurology. Dr. Koski received her medical degree from the University of Maryland School of Medicine. She completed residencies at the University of Maryland Medical System and Jackson Memorial Hospital in Miami, Florida, and fellowships in neuromuscular disease, neurochemistry, and neuroimmunology. Her major research interests includes complement and inflammatory neuropathy, ovarian hormones in neuronal survival in central nervous system inflammation, validation of clinical criteria for CIDP, as well as outcomes relative to the clinical course and therapy of these patients, as well as those with MMN. She has co-authored numerous book chapters, as well as articles for journals. Dr. Koski served on the U.S. Food and Drug Administration panel on CNS and PNS drugs and continues to serve as a consultant. You're going to find her presentation very enlightening. Thank you.
This is my first opportunity to talk to this group, and I must admit I appreciate the invitation. I also appreciate the tour de force that Dr. Lewis went through, and I know he presented a lot of information, but you're going to hear some repeated terms that is hopefully going to make it easier for you to understand what I'm going to be talking about. All right, now I'm going to be talking actually about two of the most common inflammatory neuropathies. These are actually quite serious, but the nice part about them is that they are quite treatable, and early diagnosis and appropriate management improves outcome in these particular people. All right, first of all, GBS, which is probably considered in many patients a neurologic emergency, is a very serious subacute inflammatory neuropathy where people develop paralysis and sensory loss over 1 to 4 weeks. And after a brief plateau, they will then go through a progressive improvement. It's monophasic and it's self-limiting. That, however, does not mean that it isn't dangerous. It is. The triggers actually most commonly are a preceding infection. Upper respiratory tract, you know, that cold you had last week, or a diarrheal illness are really most common. Now, there are actually several other things that have been implicated or at least associated, but they're really not quite as strongly documented as the antecedent infection. These include things such as vaccination, surgery and trauma, and a variety of different agents as well as systemic diseases. Now, the thing is that we're really still talking about a rare or orphan disorder. Each year in the United States, it only affects about 1 to 2 patients per 100,000. Usually males are twice as frequently involved as females. And despite the fact, as I said, that you can actually have severe paralysis with this, as a result, 40% actually may continue to require rehabilitation, and 10 to 20% may have significant disability at 1 year. Now, having said that, usually 80% of patients that have this disorder are able to walk at about 3 months. Now, this is some of just a list, and I'm sorry that I don't have a pointer, but we talk most frequently about weakness. And the paralysis actually takes place in both the proximal and distal extremities of the legs greater than the arms, but it also involves the muscles of swallowing and facial muscles. As a result, people actually sometimes have to have a feeding tube. In addition, about 40% actually will require a ventilator. You can be paralyzed head to toe and still have a good outcome. Some of the other things that patients commonly have are pain with this. This can be related somewhat to swelling of the nerves and even position of the patient. It can happen during the acute clinical course and then also during recovery from different types of mechanisms. One of the other things that is very commonly associated with this is what we call involvement of the autonomic nervous system. Typically, it's a little bit of hypertension and a little bit of a rapid heartbeat. So not something that will actually be a major problem. In a small percentage of patients, however, you can have severe fluctuations in your blood pressure and sweating and a variety of other things, including constipation and some other gastrointestinal involvement from that autonomic involvement. All right, the etiology, and please don't get intimidated by this cartoon. I'm not going to go through it in detail because what I want you to realize is that it's actually a whole cascade of immune events that affect damage in the peripheral nerve. But the thing that is actually most specific is that it turns out that if you have this preceding infection, and here I've actually just done a little cartoon of a bacterial agent that causes diarrhea, and it's actually the most common cause of diarrhea in the world. That's Campylobacter jejuni. If you get an antibody response to a surface determinant of this organism, it turns out that you have a very similar molecule in the peripheral nerve, and those antibodies cross-react. This is the reason why we think that, that this preceding infection really triggers the whole event that occurs. But the other thing I think that's also an issue is it turns out that depending on the type of antibody response that you could get, you get different forms of Guillain-Barré syndrome. The most common variety in the United States, about 75 to 80% of the cases, is something called acute inflammatory demyelinating polyneuropathy, which is AIDP. In this particular condition, what you actually is happening is the antibodies that usually are in response, to an upper respiratory tract infection, probably interact with something on the myelin. Now, Dr. Lewis actually discussed some of the terms. So when we're talking about the peripheral nerve, we have and this is, by the way, a motor nerve. We have the motor neuron has an axon that goes out prior to a very elaborate end plate that sits right on the skeletal muscle. Stimulation or firing of that neuron actually causes the fibers of your muscle to contract. That's how you walk, it's how you lift things, it's how you move your legs and extremities. Now, it turns out that the axon or wire that was alluded to is covered by a series of cells, Schwann cells, that really wrap around the axon with a very sort of fatty containing membrane called myelin. if you want to think of myelin, it's a bit like if you have an electrical wire and you have that insulating substance on top of it. You know, if that gets stripped, the wire shorts out. And indeed, it's the same thing that happens here. You have an immune response that's attacking the myelin, and as a result, you get areas of that nerve that are not myelinated. And what happens is the impulse down to your skeletal muscle just dies out. You know, it tries to keep on conducting, and it goes smaller and smaller and smaller, and at some point, you lose that ability to have that impulse go down the nerve. Now, the thing is that if, however, it turns out that the antigen, all right, or the molecule on the nerve is, say, related to Campylobacter jejuni, it turns out that most of those determinants are actually on the axon, or at least the areas right around the axon itself. So as a result, you get a lot more axonal damage. Now in Guillain-Barré, there's a couple of different ways to get axonal damage. You can have say a demyelinating condition in the first part, and then because the condition is so aggressive, you get secondary damage to the axon. Or sometimes the primary target is the axon. In the case of also the last one here, AMSAM, or acute motor sensory axonal neuropathy, and by the way, AMAN, for those of you who may have heard of it, it's acute motor axonal neuropathy. In the case of AMSAM, you're getting both motor and sensory symptoms. You're getting severe damage, you know, to the nerve and causing a lot of necrosis. All of these things, demyelination actually can recover quite nicely. But once you get nerve damage, you know, that takes quite a bit longer to actually improve. Now, we do have actually some scales where we have identified factors in patients that then can be associated with poor outcome. So for instance, if you have, and if you'll notice that their age, the association with diarrhea, and what we call the MRC sum score, and that has to do really with the strength in a whole variety of muscles in the upper and lower extremities. So if you say at the first week following the onset of your symptoms, you're an older patient, and forgive me because I'm certainly including myself in this, greater than 60 years of age. If you had diarrhea in association with it, and remember, the diarrheal illnesses are associated with a higher rate of axonal damage in patients. Or if you are really significantly weak, in other words, your MRC sum score, which is highest, by the way, when it's totally normal, and lowest when it can't contract very well. You will understand that if you look out here, and that means that your sum score is actually going to be quite a bit higher. If you look out the second half, your likelihood of getting a better recovery initially within the first 4 to 6 months is going to be poorer than if you had a lower score. Now, in terms of Guillain-Barré, what we're told is that treatment is actually with either plasma exchange or intravenous immunoglobulin. We know if these are given within the first, usually 2 weeks of disease, that the patients have a more rapid recovery, spend less time in an ICU, and less time on a ventilator. Corticosteroids, which certainly had been used for many, many years, are probably really contraindicated in this disease, and we can talk more about that later if you're interested. One of the other things to also realize is the younger the patient, generally the better they do, even if they have a very severe case. So in many children, if they don't have, a really very severe neuropathy, many times they're actually not treated and their outcome is actually quite good regardless. All right, now I want to just show you some very old data, and this has to do actually with patients in a very large randomized controlled trial back in the late 70s, where essentially they looked at outcome, ability to walk, at 3 and 6 months using some of these favorable and unfavorable groups of patients. Now, if you look at the unfavorable group, what I want you to do is come on down to those patients that received conventional treatment. So conventional treatment is actually supportive care. You made sure that the patient was breathing okay, that they had good blood pressure, that you turned them, that you took care of their pain, and made sure their electrolytes were in good shape, etc. At 3 months, 11% of those patients were able to walk independently with a conventional therapy. However, if they got plasma exchange, 24% of them did. Going down to 6 months, you can see consistently almost twice the number of patients were able to walk independently as those that were given conventional therapy. In contrast, the favorable group, it's actually not quite as clear, that intervention had something quite as meaningful. All right, so I'm going to diverge now to actually probably the most chronic of the inflammatory neuropathies, and that's chronic inflammatory demyelinating polyneuropathy. Now, the thing is that it is actually, because of the fact that it can progress for years, the most common inflammatory neuropathy in the entire group. In terms of certain areas of the country, there may almost be 9 per 100,000. Many other studies say it's somewhere between 4 and 6 per 100,000. But in particular areas, and this basically comes from Olmsted County, which is in Minnesota, because of the high Caucasian population and the ethnic background, they have a very high rate. Now, similar to what we see in Guillain-Barré, these patients also have progressive weakness that is usually symmetrical, affecting both the proximal and distal muscles. And they also have associated both the tingling that Dr. Lewis mentioned, as well as involvement of large myelinated sensory fibers that involve light touch, and also knowing where your limb is relative to your body in space, and the appreciation of a vibratory tuning fork. In these involved extremities, you have a loss of deep tendon reflexes, and you're going to say, well, what's the difference with Guillain-Barré? Well, the difference is that these patients have to have progressed at least 8 weeks before you can begin to say that this is CIDP. Now, sometimes these patients really do have different clinical courses. It can be slowly chronically progressive. It can actually, sometimes, for instance, in children, have almost a sort of a prolonged monophasic course going over 1 to 3 years. Also, occasionally patients will have episodes of demyelination that are separated by several weeks and sometimes several months or longer before they become more chronically progressive. Now, when we diagnose these patients, unfortunately, we don't have a biomarker. We don't have a diagnostic test. And I think this unfortunately contributes, to some of the problems that people have when they get on medications that probably are not indicated for them. Besides the clinical signs and symptoms that we've talked about, most of the time patients will get nerve conduction velocities to look at the ability of a large number of nerves to carry an impulse and whether that impulse is slowed. In other words, we're looking for conduction block, which I described to you earlier, and slowed conduction velocities. And that helps to confirm. Spinal fluid analysis also can sometimes be helpful. But I will tell you, in about 75% of the patients, it's usually not done until later in the clinical course if the patient doesn't respond to immunotherapy. Nerve biopsy, as was commented, is usually not performed. If it is, it's to rule out other conditions such as things such as inflammatory vasculitis. Okay, now I want to mention that there are different presentations. That was a typical form, classic form of CIDP. But the point is that you can sometimes see patients who are exclusively distal acquired demyelinating, symmetrical neuropathy called DADS. There's all sorts of interesting acronyms. This is an interesting one because I think increasingly we're realizing that this probably needs to be segregated out as a different form. The reason why is it tends to be associated with an abnormal proliferation of a single antibody-producing B cell. And what it does is it produces an antibody that we can then detect in the serum, usually against the myelin-associated glycoprotein. It's a different disease from CIDP. Now, you've also been alluded to, Dr. Sumner reported on a disorder called MADSAMS. This is a multifocal acquired demyelinating sensory and motor neuropathy. Clinically, it's quite different. It actually is focal involvement of nerves as a result. It's a very asymmetric condition. And in that involved nerve, you have the loss of your motor and sensory, essentially, symptoms. Now, it responds in a very similar fashion to much of CIDP. Do I think it's a different disease? Yes, I do. I think we're going to find there's a different etiology for it, but we don't have that information quite yet. Sometimes patients can present purely with sensory symptoms or purely with motor symptoms. Sometimes in these things that they do go on with time after two or more years to develop a more generalized symptom. You're going to hear about MMN later today, so I'm going to avoid that. Now, you saw a similar table to this with Guillain-Barré. But CIDP actually has much less involvement of the tongue and palate and face. It has sometimes some compromise of the patient's ability to breathe, but, and maybe some of my colleagues can correct me, I've never had to use a ventilator on a CIDP patient. Pain, of course, is prevalent in both of these syndromes and requires specific treatment. Now, this is a difficult patient group to sometimes diagnose. And many times it's because some of the treating physicians are actually seeing these patients prior to the time that they actually develop a full-blown syndrome that easily meets the diagnostic criteria that are used for clinical trials. But that may not be when you first seek attention with a neurologist. The presentation is very heterogeneous. It has a variable disease course, as I alluded to, and as I told you earlier, there's no specific diagnostic test. We do, however, have a great deal of ideas about problems with the immune system that are present in these patients. We know that some of the patients really have chronically activated white blood cells, or T cells, which actually stimulate or control the immune response. So they're turned on. That's not every patient, but that is present. We do also know that B cells, which in their naive state don't produce antibodies. It turns out that in some of the CIDP patients, there's altered receptors on their surface that allow these naive B cells to migrate into privileged sites. They get turned on, and they actually start producing a lot of autoantibodies. Some of these autoantibodies do actually mediate myelin damage. We know that they do this both through activated macrophages, which chew up the myelin, but also through complement activation. Complement is a series of more than 20 proteins in the serum. It's a very primitive initial response of the body to infection and a number of other things. Okay, we have actually 3 treatments for CIDP that have been shown to be efficacious in a series of small randomized controlled trials, usually over a very short period of time, 6 to 8 weeks, involving maybe 30 patients. These include intravenous immunoglobulin, steroids, and plasma exchange. Oh, okay. Okay. All right. The thing is that in long-term therapy, however, the 2 that have been studied the most is intravenous immunoglobulin and corticosteroids. At this time, intravenous immunoglobulin is our sole drug that does have a FDA indication. All right, I'm going to have 3 more slides. And first of all, I wanted to show you the results of a study that the foundation did of some 860 patients who reported their diagnosis as CIDP across the United States. We completed this very late in December in 2010 and spent a bit of time in 2011 analyzing the data. What you can see is that almost 60% of CIDP patients are on intravenous immunoglobulin. About 18% are on corticosteroids. The most common reason that there were not greater numbers is because of the complication rates that you do see with corticosteroids. There's a variety of other drugs, mycophenolate methylphenol, Cellcept, azathioprine, cyclosporin, also cyclophosphamide, and occasionally plasma exchange. Plasma exchange is not a viable long-term chronic therapy because of the need for really venous access over time. Now, the thing is that when we looked at those patients who responded saying that they had active disease, you can see that it's about 58%. But there were actually a percentage that actually talked to us saying that they were either in remission with or without disability. When we say in remission, we meant that they were at least off of all drugs for 6 months of time. Now, when we actually began to look at what were some of the factors that contributed to this, as you can see with the yellow bar, and look at the time between symptom onset and diagnosis and treatment. It was 0.4 years, or about 5 months. It's interesting that those patients felt that they were in remission without disability. for at least 60% of those patients. If, however, we looked at the next group, the green bar, these were the patients that were on remission with disability. On average, they had been diagnosed within a year of onset. Now, I will tell you that overall, on average, the difference between a person having symptom onset and diagnosis for the United States is a year, a little over a year. If you actually go to on average 1.7 years, all of those patients reported themselves as having active disease with disability, and none of them were able to come off of drug. Now, you can actually continue this, and you can see those patients both in quality of life and also function. Again, were much more severe in the active disease group as opposed to those that were not. All right, so this is my final slide. I'm going to say that CIDP responds to a series of treatments, although immunoglobulin is obviously the most commonly used. Smaller intervals of time between symptom onset and treatment in CIDP correlated actually with decreased disease activity, halting disease progression, and also decreased disability. Morbidity and decreased response to treatment has been linked to delayed diagnosis, which also reflects secondary axonal damage. Poorer outcome correlated with decreased motor function, as for instance, ability to climb a flight of stairs, walk a half a mile, or run. The quality of life survey showed even moderate pain and altered emotional health actually interfered with physical and social activities. Now, I've talked to you about two of the most common inflammatory neuropathies and hopefully demonstrated to you that early diagnosis and appropriate treatment actually can limit disability and leads to better outcome in patients. Do we have any time for questions?
We have time for a couple of questions. I would like to ask you to repeat the questions that are asked because the cyberspace doesn't hear what the question is.
Okay. Any questions?